Let's Talk Nursing is brought to you by bjninform.com, a learning platform for bite-sized, evidence-based content that supports all aspects of nursing. I'm Samina Hashimi, editor of BJ Inform, and in each episode I chat with experts about topics across person-centered care, nurse well-being, and career development. Together, we'll explore their experiences and discuss practical tips and insights that you can apply to your nursing practice. Hello and welcome back to another episode of Let's Talk Nursing, the BJ and Inform podcast. Today I'm joined by the wonderful Katie Loader. She is a nurse consultant in a crisis resolution and home treatment team and has worked extensively in acute practice in the UK and abroad since 2003. Her current role as a nurse consultant in a crisis team involves assessing patients presenting in crisis, home treatment, diagnosis, and prescribing treatment plans, including medicines and psychological approaches. On a more personal note from me, Katie has been a significant contributor to BJ and Inform and is also an editorial board member for the British Journal of Mental Health Nursing, which is another journal I work on, just a cheeky shout out there. And she's always been an absolute pleasure to work with across both publications. I just couldn't resist the temptation to invite you over to the podcast. So thank you so much for joining me, Katie.
Well, thank you so much for having me and for such a wonderful introduction. I'm very humbled.
Oh no, it's an absolute pleasure having you here. So today we're talking about providing person-centered care to patients with emotionally unstable personality disorder, or EUPD in short. This is a condition that Katie is very familiar with and has also written about on BJ Inform. I'll link the article in the episode show notes for anyone who's interested in reading this. So I know there can be a lot of stigma and confusion attached to sort of mental health conditions more broadly, but especially personality disorders. So it's great to have someone on the podcast who can kind of lay down some of the facts and talk about some real life experiences that you've had with these patients. But first off, let's just start with some basics. What is emotionally unstable personality disorder and what signs or symptoms do people tend to present with?
So, emotionally unstable personality disorder, I'm going to shorten it to EUPD throughout everything that I'm going to subsequently go through just to make life easier because it is a little bit of a mouthful. So EUPD is a mental health condition and it's characterised by a pervasive and persistent pattern of unstable mood, impulsivity, suicidal behaviours and self-harm. So you might have also heard the term borderline personality disorder. Borderline is sort of quite commonly used elsewhere in the world, so in the United States, but both terms kind of broadly relate to the same symptoms and the same presentation. So EUPD is a very common personality disorder subtype. It affects around 1.6% of the general population. And as you go through the psychiatric population, those percentages increase. So 11% of outpatients and up to 20% of psychiatric inpatient population. So if you work in mental health care and healthcare more broadly, you're very likely to have come across patients who have either this diagnosis or traits of this presentation. So there's quite a lot of signs and symptoms of an EUPD. The symptoms do cause a significant distress and disruption to the person's daily function. So it includes impulsivity with a real lack of concern for the consequences of their actions, very highly changeable mood, significant difficulties regulating their emotions, interpersonal conflict. So that can be intense or unstable relationships, and this includes the therapeutic relationship with healthcare staff as well. There can be excessive efforts to avoid real or imagined abandonment, an unstable self-image, chronic feelings of emptiness, and suicidal and self-harm behaviours.
Yeah, and obviously the signs and symptoms sort of play into this, but how is EUPD diagnosed?
So the diagnosis of EUPD should be symptoms-based. So it's based on those clinical symptoms that I've spoken about, and those clinical symptoms are found in the ICD-10. ICD-11 is coming out, and that's going to categorise things slightly differently. But it is a clinical symptom-based diagnosis. There are some rating scales that are used, but none have been found to be kind of gold standard or superior. If a rating scale is used, it shouldn't be used in isolation. There should be a thorough and holistic assessment of the patient's presentation, including a history. Talking about childhood and growing up is really essential, and I'll go on to talk a bit about why that is. Risk assessment as well. And this really helps understand the extent and the impact of symptoms. And you're also looking to uncover any overlapping symptoms, because you need to rule out any differential diagnoses and understand if there's any comorbid mental health conditions that could be treatable alongside. There are a lot of real common comorbidities within sort of EUPD. For example, depression, anxiety, post-traumatic stress disorder or PTSD, and eating disorders as well. People with EUPD can sometimes report perceptual disturbances. These can be visual or auditory hallucinations, or really any of the other sensory hallucinations as well. But these kind of perceptual disturbances are more associated with past traumas, and they're not really felt to be a true psychosis. So EUPD symptoms can often be confused with other psychiatric disorders, such as a psychosis. A bipolar affective disorder is another real common condition that can be confused. So what we're looking for, the main difference between EUPD symptoms and these other psychiatric disorders, is that with EUPD, the symptoms are more variable and they're more fluctuating as well. So this kind of emotional and mood instability, the perceptual disturbances, and the self-destructive behaviours are intense, but they're short-lived, whereas with other psychiatric illnesses, they show a more consistent and a longer pattern of these symptoms as well. So the symptoms can be quite chronic and enduring, but people with EUPD can also have quite acute or crisis symptoms as well. And during these acute phases, they may be more likely to harm themselves and more likely to make use of emergency services, such as A&E, liaison services, or crisis teams as well.
So is it the case that nurses and other clinicians most often interact with patients with EUPD during crisis, or is it at all stages?
It really is at all stages. People can present to primary care and secondary care right up to sort of repeated interactions with emergency services, and that can be calling 999 in areas where there might be sort of a mental health joint response alongside police. That can be quite a frequently used service. A&E liaison, so people can present where they've done acts of harm to themselves and can come into contact with services there, and crisis services as well. And I'll go on to talk a little bit about the treatment, but the main aim is that we help people with EUPD symptoms to manage these fluctuations so the disruption levels are lessened and they don't have to make use of these mental health services as often.
To sort of prevent getting to that
Yeah,
point of crisis.
absolutely.
Yeah.
Yeah.
Yeah, that makes a lot of sense. And before we sort of talk about treatment, I think just to get kind of a bigger picture on EUPD and the symptoms, how does this usually affect people's lives? Does this affect their relationships, their work, their day-to-day routines? What does this look like on a daily basis?
Absolutely. It can influence pretty much every area of someone's life. I guess so from my understanding of my practice, people describe the relationship issues. This can be sort of personal relationships. This can be relationships with parents or parent figures, even be relationships with their children as well. Some real difficulties of establishing a nurturing relationship with people. They can sometimes be quite destructive relationships, unfortunately, because there's a tendency for these fluctuations and periods of crisis. People can sometimes really struggle to hold down a job, and obviously they can struggle to hold down sort of hobbies as well. So it just means that people's lives can sometimes become a little bit small, and they really struggle sort of developing what we call like a life worth living. And that can really impact their sense of self, their self-image. Sometimes people that have self-harmed feel very stigmatized by this. There can often be quite visible signs of their self-harm on their body, and that can kind of feed in as well to the self-image, that difficulty sort of maintaining and establishing relationships. So it really can be quite pervasive through people's lives, unfortunately.
Yeah. And I guess that's what makes care and management all the more important as well, doesn't it?
Absolutely, yes. The aim is to help support people to really develop their coping strategies so that they don't need to use mental health services, that they can develop this life worth living and they can learn all of the skills for how to kind of navigate their lives so that the disruption is kept to an absolute minimum.
What do these coping strategies usually look like?
I'm glad you've asked that because I can have a chat with you about how clinicians can help manage people with
Mhm.
EUPD. So, EUPD is really seen as a skills deficit, and the mainstay of the treatment is psychological rather than pharmacological. So, the gold standard of treatment is therapy, a type of therapy called dialectical behavioural therapy, that we shorten to DBT. And this was developed by an amazing American psychologist called Marsha Linehan back in the 90s. So the principles of DBT are really about enabling people to learn to analyze their behavior. That's really the first step. People need to recognize that their behaviors can be impactful and can be problematic at times. And then it's all about developing these skills. So, first of all, people start to develop mindfulness skills, and that can kind of be very, very grounding and just provide like a real centering of their person so they can go through more of the difficult skills. So, the next step is to develop these interpersonal effectiveness skills. So, that's how to build relationships, how to recognize destructive relationships, and how to maintain the good relationships in our lives and maybe how to safely end some of these destructive relationships so that people don't fall into this pattern of cyclical behaviors and seeking out destructive relationships when they don't work well for people. Then they'll move on to some emotional regulation works. This is about naming and understanding your emotions, challenging your emotional responses, reducing your vulnerability to emotions as well. So being less kind of emotions driven, so being able to take a step back and use those analytical skills that you've developed. And then distress tolerance skills. So this includes crisis survival skills and acceptance skills as well. So you don't have to be DBT trained in order to help people with EUPD to develop these skills. So even at a very basic level, you can do some mindfulness, some breathing skills. And the aim is really to kind of reduce this maladaptive response that people have and reduce those self-destructive behaviours and introducing other ways to cope.
That's really interesting, almost like building up these skills and this knowledge from, from the ground up.
Absolutely.
Yeah.
Absolutely. And I guess the reason why we look at EUPD as being a skills deficit is because one of the causes, I mean, I guess we don't really know what causes EUPD exactly, but one of the factors that we think is involved is childhood experiences. So people with an EUPD diagnosis or traits have often grown up in an environment that really lacks sort of nurturing. I mean, their parents can often have suffered with mental health difficulties themselves. There can be abuse, there can be lots of neglect, there can be sort of drug and alcohol issues within the family as well. So really growing up, these sets of patients or people, they really haven't developed those skills in how to manage their emotions. So the aim of intervention is to help them develop those skills as an adult.
Yeah, almost supplementing the skills that
Yeah,
I guess a lot of people would have learnt during that childhood
yes,
stage, but just got
absolutely.
missed
Yeah.
out. Yeah, that makes a lot of sense. And
Mm.
you mentioned earlier that psychological approaches are preferred over
Yeah.
pharmacological approaches. Are there any pharmacological treatments available for patients with EUPD?
Well, the guidelines don't recommend any particular medications at all. So the guidelines do say that if there is a comorbid condition, which is why it's so important when you do your diagnosis and the initial assessment is to kind of uncover whether there's a comorbidity. So if there is a comorbidity that is treatable, you can use some medications for that. But really for the EUPD or kind of diagnosis itself, medication shouldn't be used. So one of the reasons for that is that the medications really just don't work. So people with EUPD diagnosis can often be prescribed a huge array of medications. So, for example, antidepressants and antipsychotics, but they really, really don't work and are not recommended unless there's a treatable comorbid condition. So, for example, people with EUPD can experience chronic feelings of emptiness as one of the core symptoms. This can sometimes be confused with depression, and then people are prescribed antidepressants, but it doesn't work. It just doesn't alleviate those feelings of emptiness. And this can lead to people getting higher and higher doses of these medications, maybe a change in medication, and it can really bring the focus to the wrong type of treatment. So people sometimes believe that they just need to find the right medication or the right combination of medications, and when they do, they'll feel better. And that can bring the focus away from that really, really important skills-based work that's required. Also, people with EUPD can often be prescribed quite a lot of antipsychotic medication, either for the chronic symptoms or for the acute symptoms as well. So antipsychotics actually don't help with what we term as being a pseudo-psychotic symptom. So there's the psychotic symptoms that are kind of more felt to be trauma-based rather than a true psychosis. So I have done some research around the use of antipsychotics and really looking at the evidence base. And the evidence base it's not really there. It's not great. And where there is a little bit of evidence, you have to take it with a real caution, because the research is often sponsored by the drug companies that make those medications in the first place. So there's a lot of bias there. So there's a tiny bit of evidence that olanzapine can help reduce some of these pseudo-psychotic symptoms, but there's also conversely evidence that olanzapine can actually increase self-harm behaviours as well. So it's a really tricky area of prescribing, which is why I think the NICE guidelines really recommend that if you are going to use medications, it has to be really, really well thoroughly thought out, lots of involvement with person-centered care and getting the patient involved in the decision making. You need to use the lowest dose possible to achieve the response that you want, and use the medication for the shortest amount of time possible as well. And really, when someone comes into your service, and if you're a prescriber, like myself, I'm a nurse prescriber, we sometimes look at de-prescribing as well, because obviously patients can end up on medications for a long period of time. Maybe they were started something for a specific reason, and that's just carried on and on and on. So de-prescribing is sometimes really, really helpful as well, especially if we kind of bear in mind the side effects and sort of metabolic effects of some of these medications as well.
Yeah, no, that's really interesting. I actually read your article on
Good.
prescribing
Yeah.
antipsychotics in EUPD. I think it was published in the Journal of Prescribing Practice.
Prescribing practice, yes,
Yeah,
that's right.
yeah.
Yeah.
I'll link it in the show notes if anyone's
Oh,
interested in reading that. But
yeah, that would be great. Yeah. That kind of came out of a real curiosity of mine, because it's very common practice. And I think when it's common practice, people just sometimes fall into a trap of thinking, well, because everyone does it, there must be an amazing evidence base. But I mean, often when you actually do that deep dive, you realize that the evidence base is sometimes a little bit patchy, but people can kind of use things just kind of routinely. And there's a difference between what the research shows us and what our kind of anecdotal and personal experience shows us as well. So it's good
Mm.
to kind of weigh everything up.
Yeah, no, it was really interesting to see in the article that despite there not being any recommendation to use antipsychotics, and
Mm,
also the research being a little bit ropey,
yes.
this is the technical
Yeah.
term for that. But they're still so heavily prescribed in EUPD, and I guess it is, like you say, just kind of a routine thing. It must have just begun at some point and then
Yeah,
continued as a
and then just
practice.
carried on. And I think it's probably because of when something started, it's very difficult sometimes to stop it, and then you fall into a bit of a pattern of increasing the doses, and then maybe trying to find an alternative. And actually, that can sometimes be helpful for people, but like I said, sometimes it can really draw the focus to the wrong kind of treatment, and it's so easy to take a medication, and you can understand why people want to kind of feel that medication is the answer. Behavior change is really, really tricky, but supporting people and really talking to them about the evidence base is absolutely key for their understanding of why you're maybe doing the things that you do and recommending the treatments that you are.
That's really interesting. And speaking of sort of research that you've done,
Mm.
a few years ago you also conducted some research into nurse attitudes towards
Yes.
patients with EUPD and how this kind of affects care provision. From this research and your sort of personal experiences, what have you found to be some common nurse attitudes towards patients
Mm.
with EUPD?
Yeah, so that was another really interesting bit of research to do. I think there's so much research out there about the attitudes towards patients with EUPD. But actually, I kind of wanted to have a bit of a deeper think and say, yes, we know that those attitudes are there, positive and negative, but how does this impact us as healthcare professionals? How does it impact the patients and how does it impact the care that we deliver? So sadly, EUPD is a really stigmatised illness, and studies show that staff view this patient population as being more in control of their presentation and behaviours than people with other mental illnesses. And this research showed that there was a lot of negative sort of connotations and a lot of negative attitudes amongst nurses. So those could include frustration, right through to kind of dread and fear at having to manage these patient population, judgmental attitude towards their care, and that included the provision of care and also sort of a belief of whether these patients are actually worthy of care in the first place. And there's really common labels that are attached often to EUPD, such as manipulative or attention seeking. And unfortunately, this can lead to staff really feeling very hopeless and very powerless about their ability to influence or provide sort of effective care. So these attitudes can really impact the therapeutic relationship, and the therapeutic relationship is just an absolute key to any work that we do generally, but it's even more important with the EUPD population because they're so sensitive and their relationships that they develop with people can be really, really unstable and quite sensitive. So that therapeutic relationship is so, so important. So when people hold negative attitudes, that can actually lead to them avoiding interacting with this patient population, and that can develop into a lack of trust and rejection. And again, people with EUPD are so acutely attuned to anything that they perceive to be rejection. And it could be that I would perceive it not to be a rejection, but they would. And that's the most important thing. It's that real sensitivity to what happens in relationships. But I guess it's really understandable as well. So I'm not diminishing sort of how like the impact on staff as well, because some patients can be hugely, hugely challenging. And I have personally sort of experienced and witnessed and heard about many incidents of violence, self-harm and quite destructive behaviours. And it can be hugely traumatizing for staff to deal with. And actually, I just think it's really important to talk about this and for people to feel supported. So if there have been incidents like this that you've witnessed or experienced, you don't want it to go on and affect the care that you deliver or affect the way that you work with these people. So just some of the things that you can do is seek debriefs following incidents and get some group or individual supervision going. And also the research shows that people who have that kind of support around them and knowledge and training as well, that can really positively impact on an individual and a group level as well.
And kind of on the flip side of this sort of negative stigma, maybe more along the lines of therapeutic
Mm.
relationships, how would you recommend that nurses provide person-centered care to patients with
Mm.
EUPD?
Yes, this is really, really, really interesting and really important. Person-centered care is all about providing that individual care according to people's needs and their circumstances and their preferences of that person at that time. So it really incorporates the respect and dignity and compassion and support people to develop their own skills and abilities. So all of those principles of person-centered care we can really incorporate into the care of people with EUPD. So taking as much time as you have available to get to know the person and what their goals are and what their values are is so important. Give them the opportunity and support them to make informed decisions about their care. It's important to involve carers and loved ones where that's appropriate as well. and bringing it all together and documenting this into a care plan that you can share with the patient and their carers and other services is really key, because everyone needs to know what's happening so we're not ending up working in our silos, and that care plan can follow people through the different services that they might come across, sort of bearing in mind that there can be obviously those fluctuations and people at times could access care in sort of emergency situations as well. So really getting people's preferences of what they want to happen, maybe what they don't want to happen as well, is really, really important. Because everyone needs to know what the expectations are and what to do if things aren't going as well as hoped. And keeping patients involved in their care generally, but specifically with the EUPD, can promote autonomy and decision making and problem solving. And this is all of those kind of DBT skills that we are really, really important strategies to promote. And just going back to the research that I did, so it showed that when professionals hold mostly negative views about patients with EUPD, it can mean that they often provide really kind of basic or standardized care. However, when people have more positive attitudes, they tended to engage in this more personalized, more person-centered way. And that led to more positive outcomes, not only for the patient, but it also increased that confidence and increased that knowledge in staff and made them more likely to then engage in that way in the future as well.
Yeah, that's so interesting. And I guess
Mm.
it means that actually talking about the condition, kind of reducing the stigma and giving people the support that they need doesn't just
Mm.
mean that nurse attitudes improve, it also then translates to improved patient care as well.
Absolutely, it does.
Mm.
Yeah. And it really role models as well for other people, because if you come across someone who holds a negative attitude, you can really challenge it in the way that you act and interact, and it can show people another way of doing things.
And I guess at the same time, it is kind of a challenge to implement these skills and implement these techniques
Yeah.
in that sort of real life patient
Yes.
situation.
Yeah.
And you must have had your fair share of challenging experiences as well. Was there any particular experience that you've had with a patient that, was maybe particularly challenging that you were able to come to a
Mm.
resolution with, or, just
Yeah.
anything that's stuck with you that's kind of taught you about UPD?
Yeah, definitely. So obviously sort of work at 17 years now working in crisis care, and really like my whole career has been dedicated to working in acute psychiatry. So I have come across innumerable presentations, either with the diagnosis or with the traits. And you really hone your skills the more that you deal with patients with these kind of presentations. And it is a skill, it is an absolute skill, and you might not get it right first time, but it is all about developing those person-centered ways and developing your knowledge and background knowledge of how to deal with these things. The one that really stands out recently is a young lady who had an established diagnosis of emotionally unstable personality disorder. She was referred into our service because there'd been some recent trauma. Unfortunately, she displayed the pattern of quite self-destructive behaviours. So while she was under the care of our crisis team, she overdosed on some medications. She was found by colleagues who called an ambulance, and she went to A&E to get some treatment, but unfortunately decided not to stay for that treatment and discharged herself against medical advice. She went home and then spoke to a member of staff and said, I want my medications reviewed. So then she was booked in the very next day to see me. So the overdose took place on Saturday and I was booked in to see her on the Monday. Really, what she was saying, what she wanted was for me to prescribe her double benzodiazepine. So she was already prescribed a benzodiazepine called clonazepam. And what she wanted on top of that was another benzodiazepine called lorazepam. So that was kind of the negotiation that we were going in for. I viewed things very, very differently. What I was coming at was, actually, you haven't had your physical health reviewed, and that is the absolute first step that we need to establish, is that whatever care we give you, we need to know that you're safe as a very basic standard. So she was very, very dismissive of this. She was just like, it doesn't matter. What I want from you is these medications. I don't feel unwell. But really, my argument was, there could be all sorts of things going on at a level inside your body that you might not be aware of. So I brought along a colleague who does physical health checks in my team, and I also, just to add the pressure on, had a student as well who was observing. This was a really lengthy consultation. It took around about an hour and a half. And really, we were kind of in almost like a negotiation, really. So the patient, on the one hand, wanted something from me that I felt was very, very unrealistic and I wasn't willing to do. But there was other things that I did want to do for them. So really, it was about validation and empathy and listening and all of those really, really important nursing skills that I'll talk about a little bit later. So what I really wanted to understand why they wanted this from me, what was going on that made them think that they wanted this sort of medications. And really, it was because underneath they were really, really struggling with managing their anxiety, managing their emotions, and they thought that if they had just had more medication, that would be helpful and they would be able to manage it more. So really, what I've spoken about sort of engaging and providing as much knowledge as possible. So engaging that person in this kind of shared decision making. So I spoke to them about the importance of making sure that they were physically safe at a basic level, and they did agree to have some physical health checks. I spoke to them about the guidelines as well, and that actually what they're asking for, I'm not sort of morally able to do. And if I put those prescriptions through, I wouldn't be allowed to do it. So it's not that I don't want to do it. It's just that this isn't something that would be reasonable within the context of the guidelines that we have, but reassuring them really that I want to help them. I'm not just dismissing them. I really, really want to help them, and let's have a think together about what else we can do. So that kind of helped them develop some trust in me, that I was there not just to dismiss them and say, no, I'm not going to do that and walk away because I think that that's unreasonable, to give them the reasons why and to say that I'm there to help them think about other things. So we did have to think about lots and lots of other options, and I gave them those options as well. And one of the really important things about person-centered care is giving someone choice. So I said, what else can we think about? How else can we help you? Because what we would like to do is use the medications maybe to help you feel a little bit more settled and feel a little bit more stabilized, so we can do some of those skills-based work. So it's introducing that notion that the medication is there for a purpose, not for forever. And actually, it's that skills-based work that's really, really important. So what I often like to do is do something now, make a plan for the medium term, and then have a think about options for the future as well. So then the person knows that they've got a plan A, they've got a plan B, they can have, there's lots and lots of different options, because it's really important to instill hope as well. Hope for the future, hope that things can change and that there isn't just one thing that is going to happen now. And if that doesn't work, then that's it. So we ended up coming to an agreement that I would, they'd already increased against medical advice, a medication that their GP had prescribed. So all we ended up doing in the end was I agreed that I would just let the GP know that they'd done that and ask the GP to prescribe that dose so that they had that medication available to them. And actually the negotiations worked so well. I had some really lovely feedback from the student that I had with me. She said that I'd remained really, really calm throughout, which was quite nice for me, because at times I was getting quite frustrated. And I think that's just a really natural human response and nothing to be ashamed about. But what was really important was I didn't let that feeling and emotion in me come out or impact the patient care or impact the negotiations that we were having. And the young lady in question was so happy with what we'd agreed that actually when I spoke to her a couple of days later, she said, I've kind of got what I want from you and I'm happy not to be under your service anymore. So I'm happy for our next contact to be a discharge. And that all happened within the space of less than a week, going from feeling suicidal and overdosing to us checking the physical health and making sure that was all under control, providing this medication review and some options of what could happen now, and what could happen in the future, to being so happy with what we'd done that they were happy to go back to their regular care team with all of that in the background as well, that they could action through their GP in the future. So a really, really challenging consultation, lots and lots of emotions in me, but I just kind of held in mind all of those really important principles that we've talked about and got a really, really good resolution.
That sounds like a very difficult
Yeah.
situation to be in. But no, it's great to hear that you kind of managed to come to a resolution in the end, and it's lovely that you shared that you were starting to feel frustrated
Yeah.
and feeling emotional. Because I mean, I do this too, you know, when you're having a conversation with a person, you kind of
Mm.
like to match their sort of emotional state a
Yes.
little bit,
Yeah.
and I feel like it's natural to do that. But yeah, just how you
Yeah.
can kind of keep your cool, be calm and collected, and you know, deliver those
Absolutely.
principles of person-centered care in such a
Yeah.
tense environment is, yeah, it's
Yeah.
astonishing to me, really.
It's so important to role model. You know, like you said, we don't need to kind of match each other's emotions and then allow that to escalate. Actually, what I can show is that you can talk about really, really difficult things whilst also being able to kind of hold those emotions that you have as well. And also, I'm just very aware that it might feel like it's really easy for me to kind of sit there and talk through all of these principles and how important it is that we do things. But I also think it's really important to show that I do it as well in my practice, and I struggle with it as well in my practice at times. And, you know, it is all about learning. And despite the fact that I've been a nurse for sort of a couple of decades now and doing crisis work for sort of 17 years and counting, that I'm still learning all of this as well. And it's exciting, really, to be able to kind of feel like you're still learning things and still developing and still able to put things into practice. Because I think, you know, once you think that you know everything and it's become boring, then maybe the job's not for you anymore.
Mm. That's a really interesting point, I guess.
Mm,
It's easy to sort of, when you've got a clinical
yeah.
diagnosis, to just lump everyone into this kind of broad EUPD category,
Yeah.
but every patient is an individual, aren't they? So
Mm.
every situation is going to be different.
No, absolutely. And every situation will need a different set of skills as well. So, yeah, it's thinking on the spot and trying to kind of work through things and not be afraid of going wrong and not being afraid of naming things as well. So, when I was with that young lady, I actually said to her, you know, you're putting me in a really, really difficult position here, and I'm just not willing to do it, and kind of bringing it back to that real sort of personalized way of engaging with them.
Yeah, just have a person-to-person
Yeah.
interaction. Yeah.
Yeah, yeah.
So now to take a bit of a break from the hard-hitting stories, I'm
Yeah.
going to ask you about your three key actions. So these are three sort of important practical actions that you would recommend nurses to start implementing when providing care to
Mm.
patients with EUPD. So what is the first key action that you would recommend?
So, my first key action is to take a trauma informed approach to caring for people with an EUPD diagnosis or EUPD traits. So, the reason for this is that research shows that when healthcare professionals take the time to see the person behind the patient, they can really develop empathy and a deeper understanding, and it can promote a more positive outlook and enhance that therapeutic relationship. So, working in a trauma informed way really keeps in mind that patients with EUPD can often have experienced multiple traumas throughout their lives, and that this can affect their neurological, biological, psychological, and social development. And this can impact their ability to feel safe and develop these trusting relationships with healthcare professionals. And that can be a real barrier to accessing and benefiting from care. So, if we treat people with this trauma informed approach, we can really, really break down those barriers and make sure that people are able to access the care that they need in a really nurturing and supportive way.
Oh, amazing. And what is your second key action?
So, my second recommendation is to be aware of the treatment guidelines. So, obviously, working within guidelines and evidence based care is so important for every single area of nursing, but particularly so for people with emotionally unstable personality disorder. So, The NICE guidelines kind of set out and detail the treatment recommendations. And this is for kind of any level of service, whether it be primary care or emergency care. And it really kind of brings home that the key is developing an understanding of the presentation and focusing on what self-management skills are needed within that episode of care. And this should be supported by a robust care plan and a risk assessment as well. And the guidelines recommend that your risk assessment should and can guide what interventions and referrals are offered, but also bearing in mind that this needs to be balanced with positive risk taking as well. Inpatient admissions can be offered, but really this should be a last resort, and we need to bear in mind that the aim of treatment is to develop those self-management skills, and this is less likely to happen if an inpatient admission is sought during each period of crisis. And to remember as well that the guidelines do not recommend any particular medications unless there are comorbid conditions that are treatable with medications. And the aim of any pharmacological treatment is to use the lowest dose possible to achieve your desired response and for the shortest period of time.
Hmm. And lastly, what is the third key action that you would recommend?
So my last key action is to really develop all those useful nursing skills to help you effectively care and treat people with an EUPD diagnosis. So this is your real key set of interpersonal and communication skills. And you will need to be a role model for how to effectively engage these skills. So they include being compassionate, empathetic, and non-judgmental. And you need to bear in mind that this is a really stigmatized illness. You need to demonstrate that you're listening and taking the person's experience seriously and validate their emotions and concerns. And this can help foster trust and help develop that therapeutic relationship. You need to be clear and consistent, and you need to do what you say you're going to do. And bear in mind that people with EUPD can be really sensitive to what they perceive as rejection. So it's really important that, bearing in mind the example that I gave earlier, don't feel kind of compromised to provide things that you actually know that you can't give or feel that isn't possible to give. Be really clear and consistent about what you're going to do and what treatment is available. And this can kind of really develop that trusting relationship again. And you need to convey a sense of hope that recovery is possible as well.
Thank you so much for sharing those actions. I think, yeah, the last one in particular was really highlighted in your sort of personal
Mm.
example. And I think these sorts of recommendations would be really helpful for a nurse who's interacting with a patient with EUPD, just to sort of keep in mind, especially in those challenging situations. It's nice to just kind of have advice
Mm.
to fall back on, I guess. So now we're moving to our final segment of the episode, and that is the scenario-based reflective question. So I'm going to read out a scenario about a patient with EUPD, and Katie, you'll
Mm.
be sharing how you would respond in this situation. And for our listeners, feel free to pause the episode after you've heard the scenario and think about what you would do, and then hit play to
Mm.
hear Katie's approach. So the scenario is you are a nurse who's working on an acute inpatient unit. A patient with emotionally unstable personality disorder has recently been admitted to the ward and is asking whether they can leave to go out to the shops. However, the patient has in the past bought items to harm themselves with, and you think that
Mm.
they're not currently safe to leave. In response, the patient
Mm.
threatens to harm themselves on the ward unless you allow them to go out. What can you do
Mm.
to de escalate the situation? So, Katie, I'm not sure if you've encountered a similar situation in your experience, but what would you kind of do
Mm.
here?
Yes, so I've absolutely, in my time working in inpatient units over the years, definitely encountered sort of broadly similar situations where there is, unless you do this for me, I am going to do this thing that may be harmful or may be disruptive. So I would recommend taking the patient off of the main ward, maybe to somewhere where we would kind of term like a low stimulus environment, to somewhere where there isn't that kind of influence of lots of noise or chaos, or maybe other people kind of watching what's going on as well. So really what you need to understand is why they're saying that, really. So we need to understand the function of that behavior. So there's, so broadly speaking, really two functions of behavior according to psychology. It's either that you are trying to get something or you're trying to get away from something. So really in this situation, the patient wants their needs met, and maybe because of the kind of impulsive nature of some of the symptoms that they may be experiencing, they often want their needs met kind of immediately. And then at times when there's a negative response, they can feel very rejected. They can sort of maybe interpret what you're saying very, very negatively. So what you need to do is really be very open and very honest, and really convey to them that you really want to help them, and you need to understand where they're coming from, and that you need to kind of come to an agreement, because you would like ultimately for them to be able to go out and maybe go to the shops and get what they need, but you need to also be reassured that they're going to be safe doing that. So I guess you're kind of again entering into a bit of negotiation and kind of an agreement as well. So don't ever feel compromised into agreeing with something that you don't agree with. As a nurse, you are absolutely duty bound to make sure that your patients are safe. So you can be open and honest with the patient and just say, look, I'm a little bit worried about how you've been behaving, or sort of like maybe some of your presentation on the ward. And I'm very aware that in the past, when you're feeling like this, you've gone and bought items that you might use to hurt yourself. And what I don't want you to hurt yourself, and I don't want you to also. The other thing to bear in mind is that they might come back and kind of pass these items on to other people as well, bearing in mind that you'll obviously have lots of very vulnerable patients on the ward. So you're keeping everyone safe in doing what you're doing. So you really need to kind of use all of those listening skills. You need to listen to the patient and what they want, try and understand the functioning of the behaviour and the threats that they're making, what's underneath that, why they're behaving in that way, maybe role modelling a different way of managing. Maybe if they're very, very heightened and making lots of threats, you need to use those DBT kind of skills, the mindfulness, the breathing, the grounding techniques to bring those levels of high emotion and high arousal down, that you can have a reasonable and effective conversation. So really you're kind of, what you're doing is negotiating from your standpoint is, I want to help you. How do I get to the point where I'm able to help you so that you can leave? And really like kind of lay your expectations as well. Say, I need to be reassured that you're not going to go and hurt yourself, that you're not going to bring anything back that might hurt you or hurt other people. How can we work together in that really kind of person-centered, shared way so that we can both achieve this same goal? And that's how I would kind of approach it.
It never ceases to amaze me when people can sort of stay cool and calm in a
Mm.
challenging situation like this and, also come to an actually useful conclusion. I'd probably just completely panic. So, so this kind of
Yeah.
work is just really impressive to me.
Oh, that's very kind. I think, yeah, it is using all of those skills to, yeah, just remain really calm despite it maybe being a very pressurized situation. And really, I think what helps is that ultimately you're not just saying no and that's it and trying to get out of the situation as quickly as
Hmm.
possible. Ultimately, you want to say yes. So it's in your interest and the interest of the patient that you both remain really, really calm and come to a conclusion that you're both really, really happy with.
Hmm.
And
Yeah.
you're kind of building that relationship as well. And then in the future, maybe that person will trust you more because they know that they've been able to kind of go through that experience with you of that negotiating, of feeling listened to, and they might kind of come to you again.
Yeah, I guess that's something we haven't really touched on much, but sort
Mm.
of building up that trust for the long term as well, so that if anything does happen later down the line, you've got that good relationship to fall back on.
Absolutely, absolutely. And it's so important so a really important principle that's really stuck in my mind from doing kind of prevention of and management of aggression training previously is that you really need to, if someone is very, very heightened, or they're kind of acting in that way that makes you feel quite unsafe, it's really reminding people of that relationship that you have with each other and that therapeutic relationship, because people are less likely to act in a way that's harmful if they're reminded that you have that connection. So it is like I said, it's absolutely key to everything that you're going to be doing.
Amazing. And yeah, thank you so much for sharing your insights, your stories, and advice today, Katie. As usual, you've been an absolute pleasure to talk to.
The pleasure's been all mine, and thank you again so much for inviting me on. It's been a really, really enjoyable experience, and
Oh,
yeah, really,
amazing.
really great to kind of go through all the research again, kind of reread all of that evidence, and try and pull it all together. And hopefully, it's been helpful to the listeners.
Oh no, I'm sure this would be extremely helpful to anyone who's listening and to anyone who's even remotely interested in EUPD. So yeah, thank you so much. If you enjoyed this episode of Let's Talk Nursing, do follow us for new episodes and share with your colleagues. For more resources and past episodes, visit bjninform.com. Thank you so much for listening and see you next time.